Hi, this is Dr. Gardner, and I am recording the Respiratory System Lecture for Nursing 517. Here are the objectives. I'm not going to read them all. You're quite capable of reading the objectives, so I'll leave them up here for a second so you can see where we will be going with this lecture. So we'll start off by talking about some of the medications that we're going to cover in this lecture. I have oxygen first because I am not going to lecture on oxygen. Oxygen is something I want you to go and research on your own, read it in the chapter, look at it in the slides. But oxygen, you will rarely prescribe oxygen in your practice. You may have to use oxygen if there is an emergency that goes on in the clinic, and you have to put a patient on oxygen, and probably 911 is going to come and they will be handling all of that. So we won't have a lecture on oxygen, but it is some information that you do need to know. We will go over some bronchodilators. We'll talk about some Leukotriene modifiers. We will talk about inhaled corticosteroids, antihistamines, and decongestants, and some cough preparations. So we'll start with an overview and the treatment options of asthma. So let's go over the pathogenesis of asthma. So in this diagram, you see a normal airway. You know, the muscle is smooth, the airway wall looks good, there's a good flow. And then you see the what happens during asthma, where there's a narrowed airway, there's limited flow in there, the muscles are tight, they're spasming, the airway wall is thickened, there's mucus that's building up. So what happens when someone is having an asthma attack? Well, they have a bronchoconstriction, and those bronchial secretions lead to wheezing. So that's why, patients, if you're going to ask them about their medicines, they want a rescue med because that rescue med opens up the airway and helps them to breathe right away. But the controller medications are much better because they keep them consistent. So some of the short-acting beta agonists, you've probably seen like Zopanex, ProAir, Ventolin, Proventil. I'm not quite sure if Alupent is still on the market. That one may actually be gone. So we'll kind of move that one. But the short-acting beta agonists are the rescue medication. So easy to remember. It's short-acting. It's going to happen really fast. The long-acting, on the other hand, those are for daily use, like the Ceravent, the Foradil, the Brovanas. So one thing that's really important for you to know is you do not use a long-acting beta agonist alone. It has to be used when combined with a corticosteroid. And why is that? Used alone, it increases the risk of death. So do not use those long-acting beta agonists alone. So that's why I have the little stop person there. He's telling you don't do that. Okay, so here's some compare and contrast. So albuterol, that is a selective beta-2 agonist. It's got minor beta-1 activity. That is safe for children of all ages. You can prescribe albuterol to all people. That is one of the safer ones. Salmeterol, that is more of a selective beta-2 when it's compared with albuterol. It has minor beta-1 activity. That one has a 12-hour half-life. You can't use that one in children that are younger than 4 years old, and never use it by itself. Terbutaline would be okay to prescribe to mothers who are pregnant. It's a category B, which is generally okay to use. And The ipratropium bromide, that is good. It blocks the muscarinic cholinergic receptors and it causes smooth muscle relaxation. So, what do we know about inhaled formulations of drugs? They are absorbed quickly, and that's due to the enormous blood supply in the alveoli. So, inhalation drugs are absorbed very quickly, and that's because of that enormous blood supply in the alveoli. So these are just some of the adverse drug reactions of some of these medications. Like they're usually transient, they'll go away. The tremors, with albuterol, a person may have tremors, a little shakiness, a little dizziness or nervousness. A patient on salmeterol may have an increased risk of having an asthma exacerbation. And then if they're used with tricyclic antidepressants or the MOAIs, then they have the potential to potentiate effects of a beta agonist on the vascular system. So let's get into clinical use. Albuterol. Albuterol is one that, of course, it's a rescue medication, and 2 puffs every 4 to 6 hours as needed. That is an as needed medication. So the nebulizer dose for albuterol is 2.5 milligrams. And you can repeat a nebulizer dose twice after 5 to 10 minutes. And you can combine albuterol with ipratropium. So I do have a little note. So some people have exercise-induced asthma. So they may take 2 puffs of their inhaler 15 minutes before they exercise. The salmeterol discus we kind of talked about, that's 1 puff twice a day. That is not an as needed medication. That is one of the daily medications. Don't use it alone. Combine it with an inhaled corticosteroid. So that one, if they're not already taking this medication, they can take 2 puffs about 30 to 60 minutes before they exercise. But remember, if they're already taking it, you don't tell them to take it again. They can only have 1 puff BID. But for exercise, it can be 2 puffs, 30 to 60 minutes before exercise. And I have theophylline on our chart, but we will go over theophylline a little bit more in detail. Step therapy. So I want you to kind of understand this chart. So if they have intermittent asthma that's coming and going, the preferred is a short acting beta agonist as needed. So step 2, they may need a low dose ICS, or they may need some theophylline, some cromolyn. Theophylline is an old drug. We really don't use that anymore. And so if they have persistent asthma, they may need a daily medication. But consult with an asthma specialist if you get to step 4. That's above your level of specialty. So you consider a consultation really at step 3. So we do step 1, step 2. Hey, you know what? They're not doing well. They're still having some problems. Send them to the pulmonologist. Also, you step up if needed, and you also step down as possible. So if they're improved, they're doing really good. If they don't need that daily and they can do with just a PRN, short acting, that's perfect. So it's okay if they're on step 1 and you have to put them up to step 2 and they're on step 2 for a little while, but then now they're doing better and you can go back down to step 1. That's okay. Just because they're on step 2, they don't have to be on that for life. It just depends. And of course, patient education is very important for each step. And we're going to go over some of that education. So like I said, you can step up and step down in therapy. The ICS is the inhaled corticosteroids. That is the cornerstone of therapy for asthma. So as you see, step one, short acting, that's PRN. And then they go over to a low dose inhaled corticosteroid. That's where we are with asthma for us. Those are really good. Okay, we're gonna do those two steps. And remember, you can add a long-acting beta agonist if they're not well controlled, but don't do it by itself. Always combine it with an inhaled corticosteroid. And we'll go a little bit over COPD. And what we're going to do is compare asthma and COPD. Here's a picture of some healthy alveoli and some COPD. Okay, so let's talk about asthma versus COPD. So the age of onset, asthmatics, usually they're diagnosed less than 30 years old. COPD is over 40 because they've probably been smoking, and they've been smoking 20 or 30 years, even if they quit. Now they probably have COPD. So that's an older population. With asthmatics, the cough, the timing is important, because they may have it right after exercise or they may do it at night. Whereas someone with COPD, they cough more in the morning. All of that mucus pools together while they sleep, and then they wake up with this horrible cough. The bronchodilator reversibility in asthma is common, but much less common in COPD. And asthmatics respond to steroids really well, whereas patients with COPD, not so much. Asthmatics, strong family history. COPD, not so much, because that is usually somebody who smoked, somebody who's been exposed to secondhand smoke. So it's not something that is running in the family. It's not hereditary. With asthma, symptoms come and go, pretty constant and progressive. With COPD, once you have it, you're not really going to clear up from it. It's going to get worse as the years go by. First line control for an asthmatic would be, of course, the short acting beta agonist, but for control, remember, control is that daily. That's the long acting. So that would be an inhaled corticosteroid. And with COPD, it's the long acting beta agonist or anticholinergics, which we will talk about. Asthmatics are unlikely to have sputum, where patients with COPD will probably have a purulent sputum. And then again, with smoking, with asthma, that's kind of variable. Some smoke, some don't, but that's not why they have asthma. But with COPD, 80 to 90% of those patients, if they're not smokers now, they were probably smokers at one time. So let's talk about Theophylline. Theophylline's really an old drug. It's not really used, doesn't really play well. There's so many better drugs now than Theophylline, but I still want you to know about it because you might see it. So, some of the precautions or contraindications with Theophylline are patients with hypertension, with heart disease, with coronary insufficiency, maybe with a history of congestive heart failure, stroke, or cardiac arrhythmias. So who is that? A lot of your older adult population. So Theophylline would not be a good drug. And it's a pregnancy category C, so there's better drugs to use than that. There's a prolonged clearance and half-life in neonates and older adults, so those are two populations you don't want to use Theophylline in. You want to monitor for Theophylline toxicity, anything greater than 20, and we'll go over some of the signs of Theophylline toxicity, but this is one that you do need to monitor drug levels for. So if you're going to put a patient on Theophylline, which again is going to be rare, you do want to check that person frequently when you are titrating that medication to get them to a therapeutic level. They can start having seizures at 15 to 20 mics per milliliter. So you're monitoring them quite often, and you may not get that big alert coming through at 20. You may see them start to have symptoms at 15. You need to know what you're looking for. They could have some irritability. They could have insomnia. They could be restless, or they could start having seizures. They may start complaining of palpitations or tachycardia. And if you're not catching those drug levels, they may have some life-threatening arrhythmias. So what are you going to tell your patients? Take this medication exactly as prescribed. Avoid large amounts of caffeine when you're taking it. The theophylline elimination is influenced by their diet, and you want to tell them all the signs and symptoms of toxicity. So say you send them home and you just write signs and symptoms of toxicity in your note, and then your patient's at home having seizures and the family's like, what's going on? We don't know. We don't know what's happening to grandpa. Papa had a seizure. They might leave him at home. Something goes wrong. Papa dies. So then the family gets a lawyer because now Papa was on this theophylline and he didn't know and the family didn't know what to expect, but Papa had a seizure. Well, they come back to your note, Nancy nurse practitioner, and you put some educated patient on signs and symptoms of toxicity. So what does that mean? That could mean anything. That could mean you told them anything. So with something like that, you want to prove what you told them. So write that out. So know those signs and symptoms and write that out. Okay. Signs and symptoms, nausea, vomiting, the insomnia, could be jitteriness, a rash, severe stomach pain, convulsions, irregular heartbeat, restlessness. They could have a rash, they could have a headache, not just your minor little headache, but oh my God, this headache, oh my God, I haven't had a headache like this. And they're on theophylline, you need to check for toxicity. All right, so we'll talk about some anticholinergics. We'll go over some of the precautions and contraindications. So, of course, if they have a known hypersensitivity to it, you're not going to give them an anticholinergic. You're not going to use this to treat an acute bronchospasm. When you look at ipratropium bromide, is that safe to give to someone who's pregnant? It's a category B. So if the risks, um, if the benefits outweigh the risks, then this is a good medication that they can get. It's a pregnancy category B, so it's pretty okay to give. The methylphenes, that is the most effective for bronchospasms. Now, anticholinergics are not approved for use in children younger than 12. And I've got some pictures of the long acting and short acting for you. Let's see. So some of the things that they may complain about, they may have constipation, dry mouth, tachycardia. They may complain of a cough, which is usually one of the things they complain about the most, or urinary retention. So, what are these leukotriene modifiers? Well, singular. Montelukast. Singular is really good. But you don't use it for an acute asthma attack. You don't substitute it for an inhaled or an oral steroid, and you don't give it to lactating women. Singular is used a lot for asthmatics, to control their asthma. Now, this Zephyrucast don't prescribe to patients with hepatic dysfunction. So what are you going to tell these patients that you're giving leukotriene modifiers to or singular? Take as prescribed. Don't take it if you're pregnant or nursing. Watch for the drug interactions. And you also want to monitor them for neuropsychiatric events. Corticosteroids, can they improve respiratory function? Well, yeah, they actually reduce the severity of asthma. They help to increase peak flow readings. They decrease airway hyperresponsiveness, and they're safe and well tolerated at recommended doses. So why do we use corticosteroids? Well, for asthma, persistent, we're gonna remember we talked about the ICS, the inhaled corticosteroids as the second step. Low dose for mild asthma. If it's moderate, they may have a daily low to medium dose inhaled combined with a long-acting beta agonist. And then, of course, if it's severe, they'll have a daily high dose, they'll have a LABA. And remember that for asthma, uh, inhaled um, inhaled corticosteroids are the cornerstone of moderate persistent asthma. We also use corticosteroids for allergic rhinitis. It's used to manage the seasonal or perennial allergies. They take that intranasally 1 to 2 times a day. So I've got some of the different inhalers that you've probably seen, like Qvar, Advair, Flovent. Um, Advair has been around forever. Flovent has been around forever. Qvar has been around. It's probably one of the newer ones, not really new. I mean, it's been around at least 10, 15 years, but that's newer compared to like the Advair. So with inhaled, you can use spacers. Remember, they need to rinse their mouth with water after each use because they can get that thrush. Even intranasally, they need to rinse their mouth with water after each use. And they also need to, the intranasal to clear their nasal passages of mucus before they use it. Now, they may complain of some itching, sneezing, some dry, bloody nasal mucus, or even nosebleeds when they're using it. So we'll go into antihistamines. So antihistamines reduce or prevent most of the physiological effects of histamine at the H1 receptor site. They strongly block the action of histamine, used for respiratory allergies, hypersensitivity reactions, angioedema, itching. It's used as a sleep aid. They're used for motion sickness. They're used for nausea. So the antihistamines have an abundance of uses. But no matter how well and what they do, somebody's always going to complain of some kind of side effect, and constipation is usually that side effect that they complain of. So we did talk about them strongly blocking the action of histamine, decreasing that flare and itch response. So if somebody comes in, they may have a reaction to penicillin, or you give them some Benadryl to help with those hives because those hives are going to drive them. Benadryl also is used for insomnia, so you may prescribe 25 milligrams of Benadryl for sleep. If that does not work, you may give them 50 milligrams of Benadryl to take before sleep. Vistaril is also used for anxiety. So Vistaril can be given 2 times a day, maybe even up to 3, and that's for anxiety. So the first generations, they're still widely used, and that's the diphenhydramine, Benadryl. The second generations, they're non-sedating, and they're more relief to allergy sufferers without drowsiness, kind of like the Allegra. I want to say Zyrtec, but Zyrtec makes some people sleepy, where it doesn't make others sleepy, and also like Claritin. So with first generation, it's caution, it's a pregnancy category B. First generation of those that, sedation and drowsiness. So if you're giving somebody Benadryl, even if you're giving them Benadryl for the hives, tell them do not operate heavy machinery until they know how they're going to act. Some people can take Benadryl 25 milligrams twice a day, 3 times a day, and they're fine. Somebody else may take Benadryl 25 milligrams and they're in a coma for a day. So you definitely want to let your patient know different people react differently. Do not do anything until they know how they will react to it. It may also reduce their mental alertness. So you may have seen antihistamines given to children, but you will not see it given to newborns and infants. those first generation antihistamines can cause like a paradoxical excitation in children. So we're very cautious on using the first generations for children. Second generations, they can be category B or C. The fexofenadine, you have to, it's contraindicated in children less than 6. Loratadine in children less than 2. Cetirizine and desloratadine syrup, um, ages 6 months and younger. We do not give that to them. Decongestants we'll go over really quickly. You know, those are used for the common cold, also for allergic rhinitis. You may have decongestants in a liquid, a tablet, a capsule, drops. But with decongestants, you want to make sure you're not telling your hypertensive patient that it's okay to take a decongestant or a coronary if they have coronary artery disease. The best thing to do if one of your hypertensive patients, Coricidin HBP is great. It's really good. It's actually for patients with hypertension, but you can also tell them to check with the pharmacist because the pharmacist knows what they can have. You need to know that they can't have decongestants if they have hypertension or coronary artery disease because that can exacerbate their condition. Oral decongestants, that's just to temporarily relieve nasal congestion, kind of helps that sinus drain, helps clear the ears. Some maybe like Vicks where, you know, it relieves that nasal congestion. They put it on their chest, says it helps to breathe. Also with the ear pressure and pain. Antitussives, people use that to self-treat their coughs, but they need to be careful if it's a persistent chronic cough that they've had smoking or asthma or emphysema, and they're just dousing themselves with antitussive. That's a problem, and you need to be asking. So, how often have you been taking that cough medicine? Um, you said you've been taking that antitussive for about 6 months now? Okay, that's a red flag. That's a problem. Also, if they have excessive respiratory secretions, you don't want to give them an antitussive and stop that. You want them to be able to get all of that out of their lungs. So you don't give an antitussive. Um, Tell your patients don't self-medicate for a cough over 7 days. If they're still coughing greater than 7 days, and yes, we say the cough is the last thing to go away, but this is a patient who hasn't seen you, they need to come and see you. Increase their fluid intake to clear all those mucus secretions. If they smoke, they need to stop smoking at that time or quit smoking and try to avoid some of those irritants that cause them possibly to have the cough. Okay, so I want you to learn how to educate your patient on these different inhalers. That's something kind of like you're going to prescribe something, and if you don't know how to tell your patient how to use it or what they're using, and they ask you, you're like, oh, how do I do this? Well, I'm going to tell you. So meter dose inhalers, that's the small particles versus the dry, and those can be used with spacers. So how to use a meter dose inhaler. So you remove the cap and you shake that inhaler up. Breathe out gently. Put the mouthpiece in the mouth at the start of inspiration, which should be slow and deep. Press the canister down and continue to inhale deeply and hold the breath for about 5 to 10 seconds or as long as they can, and then breathe out slowly. If they're using 2 puffs, wait a few seconds before repeating steps 2 through 4. And you always, if it's a new patient getting an inhaler, you always want to demonstrate how to use it because 50% of asthmatics do it wrong. Probably greater than 50% do it wrong. So the dry powder inhaler, the DPIs like Advair, that's delivered with inspiration. And so that requires them to be able to have about 30 to 60 milliliters per minute of inspiratory flow. And that's to generate the flow of the medication. These are a little bit more difficult for our elderly with COPD or emphysema. So we really need to know our populations and make sure when you prescribe something like this, have your patient demonstrate it to you to make sure that they know what they're doing. Nebulizers. Nebulizers that has a slow tidal breathing. It's just occasional deep breaths. It's less dependent on the patient cooperation, which of course, is good for children because they don't normally want to sit there. They're not really good with inhalers. But if we give them a nebulizer, we can use a mask. Mama can rock the baby so the baby can keep it on their face, maybe keep it close to the face. The only problem is that they're a little bit more expensive and difficult to bring around, so they're cumbersome. But they do have some little portable ones. Okay, inhaler technique. Shake that MDI and release 4 puffs to prime. That's on the very first time. So shake, 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 shake. 4 puffs of it. Boop, 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 boop. That's priming it. Hold it upright. Breathe out normally. Close the mouth around that MDI. See how that child has their mouth open? Close the mouth. Press down on the canister. Inhale deeply and slowly. That's important. They need to inhale deeply and slowly and hold that breath for about 5 to 10 seconds and then exhale. Now, if they're using a spacer, which is great for children, because that minimizes the importance of the timing and it also improves delivery. And it kind of helps take away that patient error. So we do use spacers a lot for children. The medicine goes into that spacing chamber and the patient can inhale it whenever they're ready. The dry powder inhalants, oh, there are so many of these. I just, have a couple pictures up here for y'all to see. So with those, they need to prepare the device. They need to exhale that normally away from the inhaler. Then they inhale deeply and quickly and hold that breath and then exhale. And they need to rinse their mouth if they're using a corticosteroid. Why? Because of the thrush. And that thrush can be very painful. All right, we'll go over some case studies real quick. I'm not giving you the answers. I just want you to think. Think about what you would do in this scenario. So we have Mr. Cruz. He's a 17-year-old Asian male. He doesn't really look Asian in my pictures, but he's Asian. He was born in Corpus Christi, Texas. He's the middle child of 3. He was diagnosed with asthma when he was 6. His last hospitalization was 3 years ago. His last exacerbation was 6 months ago. But he recently began having some shortness of breath during his cross-country runs for his high school team. So what kind of options are available for Thomas? Now, defend your selection with a rationale. So as you prepare for your exam, I want you to think, what could you do for this young man and why would you do it? And that will help you with your drug selection rationale. All right, let's go on to the next case study. We have Miss Alicia Keys. She's a 25-year-old black female born in the Bronx. She works the night shift in a busy emergency department. She's allergic to penicillin. She does not smoke. She's on oral contraceptives, pills, but she couldn't tell you what name. She's been coughing for 3 days and she's got a thin yellow mucus. She doesn't have any fever. She doesn't have any blood in her sputum, but she's been exposed to several patients that have upper respiratory infections on her job. So what would be the best medication for this patient? So I want you to know what would be the best selection and what would be the rationale behind your choice. Do you understand why you're selecting a medication for her? And finally, we have Mr. Hector Morales. He's 35 years old. He's a Hispanic transgender male. He was born in Vicksburg, Mississippi. He works as a long-distance trucker for Walmart. He's on lisinopril hydrochloride hydrochlorothiazide at 40-25. He's on amlodipine 10. He's on metformin extended release 500 milligrams twice a day. He's got ProAir 2 puffs every 4 hours as needed, and Theophylline 200 milligrams. He presents with a complaint of nausea, vomiting, headache, and dizziness that started on his way home from a late haul 2 days ago, and his symptoms are worsening. So what actions do you perform for this patient and why? Defend your answer by knowing adverse drug reactions, contraindications, drug interactions, medical history. You should be able to select the appropriate action for this patient, and you've got a lot of good history on him. Okay, so here's some key takeaways. And you'll see this on the blueprint, but you've got it in advance if you're listening to the lectures. Some things you want to know, beta 2 receptor agonists, the rescues, which ones are commonly used. The long-acting B2 receptor agonists, they're used for control, daily use. Recognize the more commonly used of those. Understand safe prescribing of both short and long-acting receptor agonists. Know how to dose rescue meds and control meds. Review the step therapy chart. Know the difference between asthma and COPD. Now, when I say review the step therapy chart, you're not going to go past step 3 because that's for the specialist. So you need to know, and that's something I want y'all to learn. When you need to know what a nurse practitioner would be responsible for, not the specialist. So know your level. So review the step therapy chart and know your level, the level of care the state board will allow you to provide. Okay. Understand about Theophylline, even though it's an old nasty drug that people really don't use anymore, we still need to know about it. Understand about anticholinergics, the Leukotriene modifiers, mucolytic agents. I didn't go over mucolytic agents in the lecture, but you have mucolytic agents in the chapters that you do need to kind of review. Know a little bit about the Advair discus, antihistamines, and also patient education of respiratory medications. So I'll give you a few minutes to write this down. You will see it again on a blueprint, but this gives you your blueprint a little bit early. Alrighty, and that is all of your respiratory lecture. I hope you got some good information. Review your slides, listen well, understand how to safely practice, and you should do very well on the respiratory section of your exam.